Thank you. Thank you very much.
You're welcome. So now it's my pleasure to introduce Professor Hironori Nakagami from Osaka University. And this is not what was written in the abstract, okay? So you have your time here.
Okay, put this one. Okay, thank you, Chairman, for your introduction. So I'm Hironori Nakagami from Osaka University. Today, I will talk about NMN in the human clinical trials. This is my COI related to today's topics. The first, I will introduce my hometown, Osaka, in Japan. Osaka is the largest city in Western Japan and boasts of having the second largest economy after Tokyo. Osaka has evolved independently and has long been an important political and economic center. Especially the South District has an entertainment area. If you visit there, don't miss the chance to try local cuisine, such as takoyaki and okonomiyaki. The most important feature of Osaka is its people, who are very kind and warm-hearted. Okay, let's start my talk. And first topic is the calorie restriction. This is a study in the monkeys. It takes almost 30 years, very hard work. Actually, the age-related mortality and overall mortality was significantly improved in the 70% calorie restriction. And also the age-related disease, such as neoplasia, cardiovascular disease, and glucoregulatory impairment was markedly reduced in the 70% calorie restriction in monkeys. What about in humans? In the human studies, some similarity, differences, and unknowns in normal aging versus aging with calorie restriction. The aging in the hypercaloric environment presents many physiological stressors result in the unhealthy aging, while aging with calorie restriction may reduce cardiovascular stress, adiposity, and metabolic disease. The effect on the cognition or grip strength, bone mineral density, and the sarcopenia, and so on are still unknown in human clinical studies. In terms of the mechanism of the calorie restriction, there is several stimulation leading to the healthy longevity, but the insulin pathway is very well conserved from C. elegans to mammalians. Actually, this slide shows signal pathways of calorie restriction. In the C. elegans and mammalians, same pathways were conserved. And more interestingly, the sirtuins is a final regulator for gene expression. And this is a NAD-dependent histone deacetylase. What is this enzyme? This enzyme is a kind of contribute epigenetic regulation and then regulates many transcription factors such as P53, FOXOS, NF-kappa B, PGC1 alpha, UCP2. The transcription factor is very important to regulate the age-related disease. That's why NAD is a kind of important regulator of age-related disease. This slide shows the NAD synthesis. Actually, the diet-derived vitamin 3 was converted to the NMN by rate-limiting enzyme NAMPT, and then MNN converted to intracellular NAD. However, the intracellular NAD was age-dependently decreased because rate-limiting enzyme NAMPT is also age-dependent decrease. That's why vitamin 3 cannot be converted in NMN in the old peoples. Professors Imai's group in the Washington University already reported the vesicle containing ENAMPT was age-dependently decreased in both mouse and human models. And more interestingly, they showed vesicle containing ENAMPT levels, expression level was well correlated in the remaining lifespan. It means probably the ENAMPT level was kind of the physiological ages markers. So again, the intracellular NAD was age-dependently decreased because NAMPT is decreased in the age-dependent. Therefore, the NAD intermediates such as NMN was to be addressed to directly upregulated intracellular NAD. Therefore, now people pay attention to the NAD as a new supplement. So again, the professors in my group already demonstrated in mice models. NAD administration for 6 months significantly decreased the body weight, but conversely, the increased the food intake. Probably the glucose or lipid metabolism was improved by NAD administration. So indeed, insulin resistance was improved by NAD treatment, and also the decreased triglycerides. Therefore, the NAD is very effective to change the metabolism in mice. So next question is, what about in humans? As you know, the human study is very difficult to set a clinical endpoint to evaluate the clinical trials target aging to extend healthy lifespan. At least in the monkey studies, it takes 30 years. Probably for humans, it takes more times. That's very difficult. But recently, the FDA challenged to set the composite endpoint of age-related disease, such as they set only major diseases: myocardial infarction, stroke, heart failure, cancer, dementia, MCI, and death. You know that now international classification of disease, ICD, was upregulated. Now ICD-11 is a new version. There is several diseases, but X extension code, XT9T, age-related disease was upregulated. Now aging-related disease is a kind of the target disease. Probably in near future, we can more set clinical trials for this disease. So this is our summary ideas to design the clinical trials target aging to extend healthy lifespan. Hard endpoint is longevity, but that is very difficult to set. So FDA challenged to set a composite endpoint of age-related disease, but still takes more time. Therefore, okay, so now FDA has several clinical trials. One of the trials is target aging with metformin trials, TAMES trials. They use metformin. This drug is an anti-diabetic drug, but they used for the aging drug because metformin has several unique pathways to upregulate sirtuin, NF-kappa B, and insulin pathway, and mTOR pathway, which lead to the health span and longevity. Therefore, now this clinical trial is going on, but still continued. So our another idea is we have more upstream of the age-related disease, and we focus in the age-dependent physiological changes, which is called frailty. So this is a Japanese criteria of frailty. That is very simple. JCHS criteria is only 5 components. shrinking, weakness, and weakness means the grip strength, and exhaustion, and slowness, and low activities, only 5 components. Especially the grip strength and gait speed can be quantified for clinical trials. Therefore, we focus on these 2 markers. And then our clinical data, I will show our clinical trials. The study design is a single center, prospective, randomized, placebo-controlled, double-blind. 60 participants were divided into 8 NMN and 8 placebo groups, and then follow up for 24 weeks. Inclusion criteria is a male patient aged 65 years or older with type 2 diabetes, and then reduced grip strength or walking speed. The primary endpoint were the changes in the grip strength and the walking speed, and also the safety outcomes. The secondary endpoint were the changes over time, the following items: plasma glucose, hemoglobin A1C, and ophthalmic examination, and the number of frailty components. So this is a study flow. Actually, the 60 participants underwent a randomization. However, the 1 patient withdrew in the NMN group, and 1 participant withdrew in the placebo group. This is the background data of the patients. The average age is very high age, almost 80 years old. That is a very old person was entered in these studies. But another marker is not significantly different between the 2 groups. So this is one of the primary endpoints, safety evaluation. As you know, the almost 80 years old, follow-up to 24 weeks. So kind of the very, always very risky patients. However, not so much adverse event. Only 1 serious adverse event is acute heart failure in the placebo group, but other adverse event was not so significantly different NMN and the placebo group. Therefore, probably NMN administration is not so, and is very safe in these studies. This is also primary endpoint, grip strength and walking speed. There is some tendency, but not significantly different in both markers. Therefore, the primary endpoint was not so significant. So one of the secondary endpoint is frailty index. The number of components was significantly different in the NMN and placebo group. So somehow NMN has some effect in the frailty index. So also we evaluated ophthalmic examination by OCT. I'm not so familiar with this analysis, but central retinal thickness, that is a kind of age-related changes, was some tendency was different between the NMN and placebo group. So recently, many clinical trials was reported using NMN in the human clinical trials. One of them is, again, the Washington University's group. This study was designed as a 10 weeks randomized placebo-controlled double-blind trials. And then post-menopausal women with prediabetes was entries. Therefore, body weight and BMI is much higher than our studies. In the results, insulin-stimulated glucose disposal, like insulin resistance, was improved in NMN group, only in the skeletal muscles. So probably in these studies, they showed improved insulin resistance in human. The other group in Japan, Tokyo University's group, was also reported the effect of NMN in the healthy older men. This study was very similar to our studies, but the average age is 70s, a little bit younger than our studies. So they only shows some tendency, some difference in the gait speed in between two groups. So this is kind of short summary of the NMN administration in humans. Still, conclusion is not yet because not so strong evidence in every NMN trials, but frailty and muscle strength and metabolic disease can be some possibility to be improved by NMN administration in human clinical trials. So this is final slide. In Japan now, a new diabetic drug, imeglimin, was now clinically used. Very interestingly, one of the mechanisms of this drug is increased NAMPT and also increased intracellular NAD, which is very good for mitochondrial function and also the increased insulin secretion. That's why blood sugar level was reduced by this drug. So probably this drug is very unique, and then we can get some results using this drug in futures. Okay, thank you for your attention.